Now we will begin the session 3, Needs on Malaria, Approaches to Address Geographic Variations. For this session, I'd like to invite Dr. Paul Willis from Medicines for Malaria Venture, Professor Ian Dondop from Mahidol Oxford Tropical Medicine Research Unit, Professor Eizo Takashima from Proteoscience Center, Ehime University, and Professor Osamu Kaneko from Institute of Tropical Medicine, Nagasaki University. Mr. Tatsuhiko Sato from the GHIT Fund will moderate the discussions. Tatsu, the floor is yours.
Thank you, Naoto, for your kind introduction. I'm Tatsuhiko Sato from the Investment Strategies Group from GHIT, and I will be the moderator for this third session. This will also be an exciting session covering the present situation in malaria and the progress of the R&D to eliminate malaria. The speakers will give presentations first, followed by the panel discussion, where we will be taking some questions from the floor as well. The first speaker of this session will be Dr. Paul Willis of Medicines for Malaria Venture, or MMV, and he will be sharing us MMV's focus and role in combating the disease. Paul, it would be great if you could start your presentation, and please keep it within 10 minutes.
Thanks. It's a pleasure to be here today to be able to talk to you about the work that the Medicines for Malaria Venture are doing. So malaria remains a global pressing challenge, with in 1922 over 249 million cases resulting in over 608,000 deaths, largely occurring in Africa, with children under 5 and pregnant women being most at risk. Medicines for Malaria Venture is 25 years old, and we are a product development partnership with the aim of discovering, developing, and then delivering small molecule drugs to treat and prevent malaria at affordable prices to those most in need. And since our formation over the last 25 years, we've collaborated in 15 new medicines being launched and over 15 million lives being saved. So from a drug discovery perspective, I just want to talk you through some of the challenges that we see at the moment that need to be addressed in malaria. And as always, in infectious diseases, resistance is the key challenge. The main drug used in treatment of malaria is a combination of an artemisinin and lumefantrine. We're already seeing evidence of delayed parasite clearance indicative of artemisinin resistance in Africa. And recently, there have been worrying reports of decreased susceptibility to the partner drug lumefantrine. We also only have one drug, sulfadoxine pyrimethamine, for chemoprevention. If we see resistance there, that will have big implications. For malaria prevention, we have limited of options available. Exciting developments recently in the launch of the vaccine, which will initially be used in children under 5. But the duration of protection and the degree of protection are concerns we hope will be further optimized in further vaccines. Pregnant and lactating women are widely affected, and we have very limited options for treatment here, so it's a high priority for us to deliver new drugs in that area. Similarly, the relapsing form of malaria, such as Vivax, found in Asia and South America, we want new drugs in this area. And if we're going to tackle the malaria eradication agenda, we need new transmitting blocking agents. I just wanted to highlight here the MMV drug discovery portfolio, which goes from, in the discovery space, very early screening, right through to candidate delivery, and then phase 1, 2, and 3 clinical trials. And I've just highlighted here the projects currently funded by GHIT to illustrate the really significant contribution Japanese partners and GHIT are making to our efforts here. Just to highlight at the moment, there's perhaps a gap in the phase 1 and 2 stage. We don't have any GHIT funded projects, but we're confident our current LO projects will deliver into that space in the next few years. What are we actually doing to tackle that risk of resistance? And we have a strategy that really divides into 3 tiers. The first is really addressing the potential of artemisinin resistance. We have a number of strategies here. So within the countries, using multiple first-line therapies to delay the emergence of resistance. And then in an exciting development, we now have a GHIT-funded project, which is to deliver a triple ACT. So this will be the first co-formulated child-friendly triple ACT, which we'll hear more about in the next talk, I'm sure. Then we have, working with Novartis, the first non-artemisinin combination drug, currently in phase 3 trials, ganaplanoside lumefantrin. Then in the medium term, it's new drugs to deal with the potential of lumefantrin resistance. And strategies here could include adding another drug into existing combinations to protect lumefantrin, such as the ganaplanoside lumefantrin ciprogarmin that Novartis are considering. Then we have 2 non-lumefantrin containing combinations currently in clinical trials. With Merck, we have carbamazepine, pyronaridine, and then with Zydus, we have Zydus 489 in combination with ferroquine. We're also looking at severe malaria, and Novartis here are looking at ciprogarmin with another combination drug here. And then below that, we have a number of molecules that are in phase 1 that have single-dose potential, and we refer to those as being in our single-dose combination pool. And the strategy here is that we could use them as potential add-ins for future combinations or to form novel combinations. Protecting children from malaria has become a very important aspect. At the moment, it's monthly treatment with sulfadioxine, pyrimethamine, and amidiaquine. Gives really good protection in children under 5 years and an additivity with the GSK vaccine. It's very cost effective, and at present, over 50 million children are covered by SMC. So we want to expand here by delivering new drugs into this space, and our challenge is to find new oral chemoprevention drugs that give 1 month of cover from a single oral dose. Another area where we're pioneering and really interested to work is finding long-acting injectable drugs that can give 3 to 6 months cost-effective protection from a single intramuscular injection. These drugs have blood stage activity, so they can decrease transmission through the clearance of the asymptomatic parasite reservoir. And we're aiming here to target a broad population, so we fill any gaps in patient populations not covered by existing drugs. They'll be small molecules, so they won't need a cold chain. They should be affordable, so there'll be real access opportunities. And we have our first long-acting injectable in clinical trials here. This is MMV371, which is a derivative of atovaquone, which started our phase 1 trials recently. And then we have a partner compound, MMV055, which is a new chemical entity we hope to enter clinical trials with in next year. Now, to accelerate the development of this combination, we're already developing a fixed-dose combination formulation of the 2 drugs. And our plan is to use that in a separate cohort in the phase 1 to speed the path into phase 2. Just again to highlight Vivax is also an important area for us. Good breakthrough recently in collaboration with GSK, where we delivered tafenoquine as a single-dose treatment that can be used in combination with chloroquine. And its registration and policy adoption has happened in many countries that have chloroquine blood stage treatment strategies, and particularly in Brazil, where the adoption and deployment of tafenoquine alongside the G6PD diagnostic kit happened in 2023. But because of the potential impact of chloroquine resistance, there will be a need for non-chloroquine-based regimes to combine with tafenoquine. Recent work on the artesunate-tafenoquine interaction suggests there is a path forwards for using this combination to treat malaria. We want new drugs to replace tafenoquine that don't need to be used with the G6PD diagnostic, and we have 2 series in discovery. They have novel modes of action against hypnozoites, and we hope to deliver a candidate here in 25. So if we look how the malaria treatment landscape could be in the future, we recognize that it's going to be a combination of different approaches. So vaccines coming through, there's also exciting work on monoclonals, but we believe our small molecule, long-acting injectable and oral projects can make important contributions in this area. So we've set ourselves challenging commitments towards 2030. We can't do this alone. We can only succeed if we work in partnership. We're grateful for the current Japanese and other partners that we have, and we're keen to explore new opportunities to work with different partners to join us in the fight to eradicate malaria. Thank you for your time.
Thank you for your presentation, Paul, about the overview of the disease and the portfolio and all the issues that we have currently and how the prevention of malaria could look tomorrow. I'm very excited about the oral tablet that we can have that could prevent malaria for 1 month. I'm excited about that. Thank you for your presentation. So the next speaker will be Professor Arjen Dondorp of Mahidol Oxford Tropical Medicine Research Unit, and he will be covering the combination therapies. Arjen, could you start your presentation? And please keep it within 10 minutes.
Thank you very much. And sorry I cannot be with you in person there today. Can you see my presentation?
Yes.
Okay, so this is following up from Paul's presentation on a new triple artemisinin-based combination therapy that our research unit has been developing over the last 9 years or so, and in a response to increasing artemisinin resistance. So the treatment of uncomplicated falciparum malaria in the whole world at the moment is with artemisinin-based combination therapies. There are 6 now being used. And that introduction at the beginning of the millennium was in response to drug resistance to chloroquine and sulfadoxine pyrimethamine. But now, unfortunately, there's a new wave of anti-malaria drug resistance, starting with the artemisinins, now around 15 years ago, reduced sensitivity of the malaria parasite to artemisinins, which facilitated the development of ACT partner drug resistance. And that's started in the Greater Mekong sub-region of Southeast Asia. Cambodia was the epicenter. And then one by one, the ACTs started to fail with high treatment failure rates. So at one moment in Cambodia, 4 out of the 6 ACTs were not efficacious anymore because of resistance both to the artemisinin component and to the ACT partner drug component. So the response to this was an aggressive malaria elimination campaign in the Greater Mekong sub-region, funded by the Global Fund, which in fact has been quite successful. I think because of that, the artemisinin problem has not spread outside the Greater Mekong sub-region, but it has emerged now independently in Africa over the last 4 or 5 years. And that is, of course, very worrying. It's not full resistance against the artemisinins, but it looks very similar to what we saw in the Greater Mekong sub-region. And the fear is, of course, that this will be the same trajectory, that it starts with artemisinin resistance, and then after that you lose the partner drug also to resistance, and then you will see high ACT failure rates and an increase in malaria, as we saw in the 80s and 90s when chloroquine resistance was rampant in Africa. So we need new drugs, but that will take still quite a long time. There are a few promising candidates, as Paul showed in his presentation, especially the Novartis drugs, ganaplacide, but still that will take a few years, and we need to act now. using existing drugs. And one approach, or the most promising approach, is to use triple combinations instead of the double combination in artemisinin-based combination therapies. So in the ACTs, there is the artemisinin component, which is a very potent drug, but with a very short plasma half-life of around 1 hour, meaning that after around 6 hours, the parasite only sees, after the last dose, the partner drug, which has to mop up the remaining parasites. In artemisinin-resistant infections, what you see in the red shaded area, the number of parasites that need to be cleared by the partner drug is much more, is in the millions rather than in the hundreds. And that makes that the parasite easily gains resistance also to the partner drug. If you combine the artemisinin with 2 partner drugs that have a longer half-life, then you prevent that the parasite only sees monotherapy of the partner drug, and that you see there in the right-hand graph over there. So the 2 partner drugs will mutually protect each other, but that needs the partner drugs to have similar elimination kinetics in the blood. And there are not that many combinations possible, but we have developed 2 different ones. I discuss one of those, which is a combination of artemether, lumefantrine, and amodiaquine. So lumefantrine and amodiaquine have reasonably matched pharmacokinetics. And another advantage of this combination is that there is counteracting resistance mechanism, and that has been nicely shown in this MDR1 Plasmodium falciparum gene at the 86 position, that the one allele reduces sensitivity to amodiaquine but increases sensitivity to lumefantrine, so they seem to counteract. And this is the triple therapy that we have been studying a lot in patients, but in the positioning, we think it's not only for the treatment of artemisinin-resistant falciparum malaria, but also in the prevention of artemisinin and partner drug resistance. That you cannot prove from clinical trials with the drug, but it relies on modeling efforts. And there are now quite a few modeling papers around. I show you one of them in this slide, where they compared different strategies to counter artemisinin resistance in Rwanda, where there is now a big problem with artemisinin resistance. And the modeling efforts, the modeling approach showed that the ALAQ introduction deployment was the most effective way to reduce artemisinin and partner drug resistance. But of course, it's also very important to look in real patients. I need to move my slides. So we have been doing large clinical trials with a loose combination of artemether, lumefantrine, and amodiaquine. By the way, you also see here the other triple we've been testing, artesunate mefloquine plus piperacin. 3 trials now, one mainly in adult patients in Southeast Asia, a more detailed study in Cambodia, and we just finished a large study focusing on African children with uncomplicated falciparum malaria in the countries you see listed there, comparing the triple therapies against their ACT counterparts. The large DTEC trial is being written up at the moment, and you will see the publication early next year, but I can already say that the results of these 3 trials combined show that the triple therapy is more efficacious than the ACT themselves in areas of artemisinin resistance. I give here the example of artemether-lumefantrine amodiaquine compared to artemether-lumefantrine in Southeast Asia. But very importantly, the triples did not have safety flags, were quite well tolerated, a little bit more vomiting than the ACT counterpart itself, but not at very high levels. So we think that this triple is now ready to take further. And for that, we have an industrial partner, Fosun Pharma, who's now producing this triple combination, artemether-lumefantrine amodiaquine, as a fixed dose combination, both as adult tablets and pediatric dispersibles. They will be tested in a GHIT-funded phase 3 regulatory trial, focusing on African children, but also a smaller study in Asian adults, which will start early next year. Results are expected in 2026. Then at the same time, we are in contact with the regulators. MMV, by the way, is also helping with that, to make sure that as soon as the trial is finished, this fixed dose combination can be registered with Swissmedic, and then also be pre-qualified by WHO, taken up in the malaria treatment guidelines, and then they will be ready for deployment and supported by Global Fund or PMI. Still, it shows how long it takes, even when you have existing drugs, to test them out, to look at the drug-drug interaction, to show their efficacy, to make sure they are safe and well tolerated. So we hope to deploy them in 2027, but maybe we can find ways to speed that up. Drug resistance, again, artemisinin resistance now emerged in Africa, is quite rapidly spreading. It will lead, we fear, to ACT failure rates, and with that, an increase in malaria transmission, malaria deaths and everything. So we need new drugs, and this triple is one of the most advanced strategies to counter this, very generously supported by GHIT, for which we are very grateful. Thank you for attention.
Thank you, Arjen, for your presentation and sharing your data of your research. The data looks so promising, and deploying triple ACTs in a large scale might look like it could prevent the emergence of the anti-malaria resistance. Thank you for your presentation. So the next speaker will be Professor Eizo Takashima of Proteoscience Center at Ehime University, and he will be speaking about his challenges in malaria vaccine development. Eizo, it would be great if you could start your presentation.
Yes, thank you so much for giving me a chance to talk today. This is very great honor for to be here to share my recent data using the innovative protein expression system. So our system is that wheat germ cell-free system. So that is made from wheat germ. So as you can see, probably not so many people want to eat the wheat germ. We eat the endosperm part as a wheat powder, you know. So, but the germ itself has all of the component for making the proteins. So we extract such kind of component from the wheat germ, then make the very sticky solution, and then put the substrates or messenger RNAs and something like that. And then just 2 days, you can see the very beautiful purified recombinant protein at the right-hand side. We can get the purified recombinant protein like this. Not always. If it is always happen, probably I'm not here. So the advantage of using the wheat germ cell-free system is that the combination of the eukaryotic ribosome and the no glycosylation machinery. It is quite matched with malaria parasite because they use as eukaryotic ribosome, and then there almost no glycosylation is happening. So using that system, we can make the recombinant malaria proteins very, very high efficiently. As compared to the E. coli system, we cannot probably compare it. Most of the trial has been successfully done. Almost 70% of the soluble protein can be obtained without any optimization. So if we put optimization more, then so far 95% of the trial was successfully done. So using this one, we created that the core resources consisting the malaria protein library. It's around 4,000 proteins now. And then by immunizing such recombinant protein to rabbit and a mouse, we created the 650 antibodies so far. And then we optimized the high throughput screening of antibodies against the 4,000 proteins so that we can profile that the antibodies naturally acquire the immunity or cell. So using these core resources, we want to get the new malaria vaccines and so on. So I'd like to explain the targets of the malaria vaccine so far. So as you know, we have 2 malaria vaccines. That is for the prevention of the sporozoite infection to the liver cells. So RTSS S01, R21, matrix M. So efficacy is more or less 30% of the prevention of the hospitalization. And the WHO says that both of the 2 vaccine efficacy is almost the same. And then the second target is the sexual blood stage vaccine. So that will inhibit the merozoite invasion. So far, the RH5.1 is the leading antigen. And then the last STMH conference, that one of the clinical trial observed the significantly reduce of the symptomatic malaria during the observation. So finally, I'd like to explain about the transmission blocking vaccine. So transmission blocking vaccine acts in the midgut of the mosquito. We have 2 or 3 main antigens, PFS230 and then PVS25 for the Vivax. The transmission blocking vaccine doesn't have any benefit. However, it is very important for the reducing the transmission. So we have done the blood stage vaccine screening with rabbit antibodies by using the 625 antibodies. Firstly, we prepared the proteins by means of the wheat germ cell-free system, and then prepared rabbit antibodies, and then put IgGs of the rabbit, and then mixed with the culture parasite, and we can calculate the inhibitory activity. So right-hand side is that the top 9 antigens, and then we focus on to the repair. That's the second top of the screening, because MSP119, ML1 is a polymorphic antigens, and EVA175 is that they have the paralogs of the EBA, so that's why that it's difficult to investigate as the blood stage vaccine. And you can see the RH5 at the 6th rank. So then, but the PF Reaper is very large and a cysteine-rich protein. If you are a biochemist, then cysteine, 1, 2 cysteines, they're always very fair to express any kind of expression. So, but they have 87 cysteines in totally more than 1,000 amino acids. So it's very difficult to produce this one as an antigen for the vaccine. So we conducted the epitope focusing. So if we can focus the functional protective epitope from the big antigen, that's very nice. So we created the truncates of the full length of PF Reaper to the 11 truncates, and we observed that antibodies against the PF Reaper 5 region has almost the same or more than full length of antibodies against the full length of the Reaper. So, so right now, by the support from the GHIT Fund, we are developing the PF Reaper 5 based the blood stage vaccine. So far, using the Sumitomo by means of the Sumitomo adjuvant, that we are getting the quite interesting result. So, I would like to move on to the Vivax one. The Vivax has the different biological features as compared to the P. falciparum because they have hypnozoids and dormant stage, and they wake up in the 9 months or so, and then get to the relapse. So the hypnozoid and then highly efficient transmission is very difficult. That makes us very difficult to control Vivax malaria. So if we can identify the people who have hypnozoid in the liver, and then if we can identify the people such individuals, if we can treat them by means of the Primakin, then that will reduce the transmission of the Vivax. So we screened more than 300 Vivax antigens to tell us the recent exposure of the Vivax malaria. So by combination of the 9 antigens, we can identify the recent infected individuals. So finally, I'd like to a little bit explain the PVS-25. PVS-25 is a transmission blocking vaccine candidate of the Vivax malaria, and we tested the messenger RNA vaccine. By means of the 2 times of the vaccination of the messenger RNA, we see the quite longer longevity of the antibody as compared to protein immunization. So as you can see, the 7 months, the protein-protein combination has quite lower antibody titers, but the 7 months messenger RNA combination, they could keep the high antibody titers, and then also importantly, transmission reducing the activity was remained. So so in summary, our system is suitable for producing malaria proteins, and then that was used for the novel malaria vaccine and serum marker candidate discovery. And in addition, the addition of the blood stage vaccine to the currently approved pre-erythrocytic vaccine in pre-falciparum holds great promise in significantly enhancing the overall vaccine efficacy. And then, transmission blocking vaccine for Vivax is key component. Thank you. Sorry, I should acknowledge.
Okay, thank you, Eizo, for your presentation. So we only have 2 vaccines for the Society stage and from WHO approved. And I think the blood stage and the transmission blocking stage vaccines are both important. And I hope both project will go further for more progress. Thank you for your presentation. So for our session, last but not least, Professor Osamu Kaneko of Nagasaki University, Institute of Tropical Medicine, will covering zoonotic malaria in the Southeast Asia. Osamu, it would be great if you could start your presentation.
Yeah, thank you very much for kind introduction. So I want to start my talk about zoonotic malaria in Southeast Asia. I thought this title could be really fit to the original title, approach to address geographic variations. But talk a little bit different from geographic variation, but anyway. So I want to summarize a little bit about treatment, vaccine, and immunochromatographic rapid diagnostic test kit that are available for, let's say, classical human malaria. So as you already, it is pretty much explained, for falciparum, of course, drug is available, but resistance is really a problem right now. Vaccine already available, but the efficacy is low. And now the rapid diagnostic test kit, RDT, for plasmodium falciparum is actually targeting antigen called HRP2. But recently, this HRP-related mutant parasite emerged. So there is a diagnostic kit-resistant parasite appear. So this is also a big problem. And then this is falciparum situation. And the other plasmodium parasite, plasmodium Vivax, Ovaria, and Malaria. In parentheses, I just put zoonotic malaria parasite that was actually transmitted from human to the local monkey. And nowadays, some parts are coming back to human, but anyway, I skip this part anyway. But Vivax, all remaining parasites are called benign malaria because they are infected only a part of the entire erythrocyte population. So the parasitemia did not reach to really high. That's why they are benign. And then a drug is available, and vaccine not available, and there is a diagnostic kit available, but the sensitivity is about 10-fold lower than the one that against P. falciparum. So this is a bit problem because of the sensitivity. And then I didn't really describe here, but as Eizo mentioned, that the Vivax and the Ovaria parasite has hypnozoid stage. So not to treat patient, but if we think about elimination, we need a diagnosis kit to diagnose who has hypnozoid. Otherwise, it's difficult to eliminate those parasites. So this is the current situation of classical human malaria parasite. So now I want to talk about zoonotic malaria. This is a problem in Southeast Asia. This parasite is actually infected in old world monkey and transmitted by mosquito. So the cycle is usually between monkey and mosquito. And so sometimes this mosquito bite human and inject this parasite, Plasmodium nosai human, and then human may develop symptom. But at this moment, there is no evidence reported the transmission among human. So this is good at this moment. And if the problem with this parasite is that this parasite infects all type of erythrocyte in the human body. So if you don't treat, the patient may develop really severe symptom and sometimes die. So it is said that severe case is more than 10%. Lethality rate is 1 to 2%. So this is really significant. And the worrying situation is that this graph shows the number of malaria cases number in Malaysia. So green bar indicate classical human malaria consisting of 4 types of human malaria. And the number in 2008, the number is 7,000. This is because of the strong effort by Malaysian government, it's really reduced. So now Malaysia has actually eliminated classical human malaria. However, this yellow part, nosai malaria was recognized to infect human, and the number is really increasing. And since 2017, looks like this is, to me, it's sort of saturated, maybe. So annually, they see 3,000 to 4,000 cases. So this is a Malaysian situation. This is a problem. And this is not the only problem in Malaysia. In Thailand, even Thailand, this parasite is actually, there is some reports, but since 2021, the case is really increased. And last year, we see more than 200 cases of Knowlesi case in Thailand. So it looks like this, to me, Thailand situation may follow the situation of Malaysia. So the number could increase more from now. So how people got infected? Because this is actually monkey malaria. So people sometimes go to the forest to take fruit for fishing or fun, and they got bitten by the mosquito and infected, and they developed the symptom in the village when they came back. But, so okay, this can be treated, right? But some people are going to the forest and stay in the forest for months for example, logging. Then this person if this person got infected in the forest, sometimes it's too late to go back. When they go back to the village, condition is so serious, or the condition becomes serious in the forest. So this is a problem with this forest. This is zoonotic malaria. So why can't they receive treatment? Number one, misdiagnosis, because microscopic diagnosis ability may be low, and sensitivity of RDT kit against these parasites is low. So that's why they misdiagnose at the beginning. So the treatment may be delayed. For the logger staying in the forest a long time, the onset, it will just take time to go back to get treatment. So what we need? We need timely diagnosis and treatment is important. So we need more sensitive diagnostic kit, definitely. And for loggers, for the person going to the forest, so maybe it's nice if they can take a diagnosis test kit and drug, and they can diagnose by themselves and treat by themselves. But probably this is not really realistic. And the second one is probably intermittent preventive treatment for, we call it forest goers, IPTF, and then basically every 2 weeks they may take a drug to cure a parasite, right? But this also may be not feasible because it's going to forest for months. So the third choice, good to develop very, very long-acting drug, like 3 to 6 months. Actually, I'm very glad to that you're already developing. So this is very nice to have. And also another good point is probably blast stage or liver stage vaccine. So this is very useful. And I'm talking about a little bit about the history of P. falciparum, Plasmodium falciparum. Actually, this has been a gorilla malaria parasite more than 100,000 years ago. But occasionally, probably at some point, they switched the host to human, and now it became a human parasite. And then along the human migration to other part of the world, the parasite also migrated to other part. Now we see, you know that already, right? So now we have old world monkey malaria parasite. It's going to human infection, but this is one direction at this moment. But if we don't control right now, probably this parasite will very likely, I believe, acquire the ability to spread among humans and may leave Southeast Asia to become an infectious disease of global concern. So I think it's very urgent to really control this parasite. Otherwise, it's too late. So what do we need? So probably additional tools such as maybe anti-gametocidal. This was actually briefly mentioned in Paul's slide. So slow single low dose primaquine is used in combination to the asexual blood parasite treatment to kill the gametocyte to prevent transmission. So this may be useful. And also transmission blocking vaccine is definitely useful to prevent the spread to establish the human-human infection. So I just added the last piece. So P. Knowlesi, so this is malignant and zoonotic. To fight against this particular malaria parasite, probably I don't know this is realistic or not, but the best solution it could be to add, in addition to chloroquine, maybe we can add this single low dose of primaquine to prevent transmission. A vaccine, I think we really needed vaccine. Otherwise, we can really control this parasite. And lastly, we need a much higher diagnostic test kit with much high sensitivity. That's all. Thank you very much.
Thank you, Osamu, for your presentation and mentioning about the urgency of preventing and diagnosing and treating the zoonotic malaria at Knowlesi. Now I would like to move on to the panel discussion. I have prepared some questions to the speakers, but I think we're running out of time, so I think I'll keep it to one. And after that, I would like to ask the floor for any other additional questions afterwards. So, so everyone has explained about the therapeutics and diagnostics and vaccines and with the falciparum, Vivax, and Knowlesi. And you've mentioned about the drug resistance emerging in Southeast Asia and Africa, and the need for more efficient vaccines, and the increase in Knowlesi. What would be further needed to combat the disease other than what you have expressed in your presentation? Paul?
So thank you for the question. I guess more funding is always the easy answer, but we never have enough funds to do all that we want. I think for us it's finding really transformational tools, and you can look at the success of long-acting injectables in HIV. We don't have any in malaria, so I think that's an area if we can push that forwards. Then we're looking at other innovations or different ways of working that could improve, perhaps having more local manufacturing in Africa to actually get more of the drugs to where they're needed. We're also looking at, could we do more of our, say, phase 1 trials in disease endemic countries so we understand the PK of our drugs earlier in actual patients. The other, say we're looking at wanting to test our compounds in women of childbearing potential. That's a population that's been neglected in trials to date. So we're trying to front load all of those reprotox studies. They're long and complex. If we could have innovations in the whole R&D space and new ways where we could, say, predict which series are actually going to deliver drugs that are safe for use in women, that would be a huge advantage. So, yeah, new innovations and areas like that, I think, could really help it drive us forwards further.
Thank you. Aryan, do you have any answers to this?
Well, that is already an impressive list. Maybe I can add, it's also important to look at the implementation architecture. So in the Greater Mekong subregion, where now in the eastern part malaria is really almost eliminated, very central in that was the formation of a community health worker or village malaria worker networks for early diagnosis and treatment, distribution of bed nets, surveillance, other interventions. That really was an important pillar, which can be translated. It's also done in sub-Saharan Africa, but there it can really be improved. So look at the implementation architecture and invest in that is, I think, also very important, using the tools we have available at the moment. Over.
Thank you, Aryan. Hazel?
So it's going to be more difficult to say something new. Well, yes. I would like to add a new diagnostic test that because HLP2 deleted deletion mutant of the parasite. In Africa also, it's getting the, quite the big problem. You know, numbers of the deleted mutant are quite oftenly identified. I often go to the Ghana recently, and then my counterpart tested the HLP negative parasite by means of the PCR, but the cases are rapidly increased in this year. So I think that the diagnostic test is also important to develop. And then the synchronization of the different country is it's also important to eliminate all of the such big areas. Yeah, that's it.
Thank you.
It's more and more difficult. Anyway, so maybe peace. If people are living peaceful, maybe many problems will be solved, I think. But it's probably unrealistic. So, but I want to just point out one more thing, because besides Knowlesi, there are other zoonotic malaria parasites exist. And because I think there are lots of theory, but I feel probably Knowlesi case increased because because we are successfully reducing parasite burden, especially in Southeast Asia, significantly. Then people may start to lose their immunity against malaria parasite. So maybe this immunity may closely act with all zoonotic parasites. So even now the case is very sporadic, but I think in the future maybe zoonotic malaria parasite beside Knowlesi may increase. This is my concern. So I think biology surveillance and more understanding of the ecology, biology is really important. Yeah, that's my comment.
Thank you. So since you've mentioned about the, Paul, you mentioned about the partnerships and funding, I would like to ask everyone about what do you consider when finding Japanese and non-Japanese partners for your project?
I mean, I guess as a scientific-led organization, we're looking for high-quality science, and we're looking for a good fit into our portfolio. And the richness of Japanese science has really given us opportunities, and you can see that in our portfolio of projects we have with GHIT already. And I think it's the science, and then it's that shared sense of common purpose, of working together collaboratively on this tremendously challenging goal. And we've had, I've been in Japan nearly a week now, and really rich and fruitful discussions with the teams that we're working with to really work together to drive the malaria agenda. So yeah, those are two things that are important to us, and I think they're hugely present in the room today.
Thank you. Arjen, do you have anything to add to this?
Well, my personal experience, I think Japan has very good malariologists, and I have collaborated with quite a few of them. I've had very good Japanese PhD students in the past. So the science part, I think Japan is doing very well. GHIT is great that we now do this project supported by GHIT. If you look globally, the funding for global health is, I think, under threat at the moment with the political changes. So I hope that GHIT keeps supporting global health projects and developments. Then the pharmaceutical industry, maybe they're, like Takeda, they now do the dengue vaccine. They have not antimalarials in their portfolio as far as I'm aware. So maybe Japanese pharmaceutical industry could also step in that space and support the development of antimalarial drugs.
Thank you.
Over.
Basil and Osamu, do you have anything? Maybe it might be hard to find funding.
Well, yeah. So the finding the partners is a very simple way. Just email them, and then if they reply me in 1 hour or something, yeah, and then definitely they are a good partner. Yeah. What else? Oh yes, and then GHIT. Our first GHIT was about more than 10 years ago, I believe. And then since then, GHIT has been supporting us almost every year. So yeah, I would like to thank the GHIT because that allows us to connect a lot of the malariologists and then different people who are good at. So that improves us quite dramatically. Yeah.
It's me. Okay. So yeah. So if I need a counterpart, I just email, and 1 hour later I get response. That's it. So. And then for just I very appreciate GHIT support so far. That's it. Thank you very much.
Thank you, thank you. I was wondering because we usually get some contacts about how to find partners for the project. So I didn't know emailing was that easy.
Sorry, I didn't mention at all about my own research, but I had a project to develop diagnostics for hypnozoids. But they are quicker. Okay.
I just wanted to highlight before we move on that the important contribution from my perspective that Japanese pharma is making, that we're working with Shionogi, with Eisai, with Mitsubishi Tanabe. We have done work with Takeda, so we're always looking for new partners, but there has been contribution from an MNV perspective into that space.
Thank you. So now I would like to ask the floor for any questions to the speakers. Please make sure to mention whom you would like to address, and also please mention your name and your affiliation.
My name is Takatsuboy from Ehime University, Japan. Thank you for the excellent discussion and the presentation. I just following comment which all of the panelists said. Based on my experience for more than 10 years working with GHIT, there are lots of, what can I say, questions like an email, or when I attend the American Tropic meeting, many people are coming to us they are very much looking for the partners. Because now the GHIT had a booth in the USA this year, and there are lots of guests was there, but they are looking for the partners. Therefore, I think I want to ask you the question: what type? I think if the GHIT itself has more, what can I say, network, you have a best networking list. So, and if we want to expand more, for example, malaria diagnostics project, maybe many people want to know who is the partner, who can be the possible partner for the proposal. So maybe if in the GHIT website, if you prefer to apply the grant, please look at this list of the diagnostics expert or vaccine expert or drug expert. That will more efficiently facilitate the number of proposals, or more expand the GHIT name throughout the world. That's my comment. Thank you.
Thank you, Tsuboi Sensei. That is actually our discussion internally. We wish we have some kind of database to like match make partners between partners.
But I think the network that GHIT has, I mean, several of the partners that we work with today were introduced to us by GHIT. So I think there's a real strength in what you're doing already, but obviously we could always do more.
My name is Imad Boksesar. I am from Osaka University. So thank you for the great talks, all speakers, and update on malaria progress. So I have two questions. The first question to Arjen, Oxford. So I wonder if part of your efficacy evaluation for the triple ACT, if you done antibody or anti-drug response or antibody kind of analysis, and you compare it to the monotherapy and combination therapy, have you done any kind of evaluation, part of the efficacy? Anti-drug and resistant, I mean, exactly. So compared to the monotherapy and combination therapy in your study. So that is the first question. And the second question to Takashima-san. So I didn't see what are the target group for the messenger RNA vaccine. So the target age group for the messenger RNA vaccine you develop, is it like for all age group, or it's like targeting a certain age group? And also you mentioned that you screen for 9 antigens out of 300 Vivax, right? So what is the criteria for selecting just 3% out of the entire antigen? Thank you very much. Okay.
Shall I start? So that is a very broad area that you address there, malaria immunology. Very much at a higher level, you can say that immunity to falciparum malaria develops slowly. In sub-Saharan Africa, where a child can be bitten every day by an infected mosquito, all severe diseases under 5 years old. After that, children can still develop symptomatic malaria, but get less ill from that. And adult people, they can carry the parasite, but don't get ill from it anymore, and also can clear the parasitemia just by immunity. In Southeast Asia and South America, the transmission is much, much lower, 1 bite per year. So there, this immunity has no time to build up. If you look at the contribution to parasite clearance, we have looked at that in our trials. In patients that do have antibodies against the parasite clearance goes down by 1 hour. So the parasite clearance half-life, if it is 4 hours, it goes back to 3 hours. So it definitely contributes. And when you design your trials, you have to take that into account as a potential confounder. Monotherapy for the treatment of malaria is from the old days, in the days of chloroquine. We think nowadays that it's much better to give combination therapy to prevent the development of resistance in the parasite. By the way, what we also do in other infectious diseases. And so we are now looking at this triple therapy approach already done in HIV and tuberculosis. Maybe that should be applied more often than is done in the malaria world at the moment. Over.
So maybe time is running. So the first question is that the two little bit older people, the more than 5, it is because of the less chance to get the Vivax. And then in the case of the p-falciparum as well, the asymptomatic or mild, the p-falciparum people get gametocyte. The symptomatic people doesn't have any gametocyte. So less than 5 years old. So the transmission blocking vaccine target is always more than 5 or so. Then the second question is that we used the 1-year cohort study sample, and we identified the half-life of the antibodies. Then we narrowed down the 9 antigens to tell us the recent exposure. That's it.
Thank you. Unfortunately, we've run out of time. So thank you again to all the speakers for your presentation and discussion, and thank you for your valuable questions.
GHIT Fund, fight neglected diseases through partnerships.